welcome to ASJ Journal Club. I'm Dr. Deniz Sarhaddi and moderator for this evening. I'm joined by my co-moderator, Dr. Maryam Zamani, and Senior Director of Publishing and Global Partnerships for the Aesthetic Surgery Journal, phaedra. Tonight, we're going to talk about a relatively hot topic, how GLP-1 medications can affect our surgical outcomes in both body and face. I'm sure by this point, most of our patients are on GLP-1s, mine certainly are, so I'm really looking forward to our discussion. Unfortunately, the authors were not available to present their work, so my co-moderator, Dr. Zamani, has graciously prepared a brief summary of the article to get us started this evening. This is an editor's choice article from our April 2024 issue, which means it's open access. So please feel free to send this to any interested colleagues, a link to the article, which you can find in the chat box below. Next, allow me to introduce our discussants. Dr. Dan Krochmal is a board-certified plastic surgeon and founder of the Krochmal Center for Plastic Surgery in Illinois. He completed an aesthetic fellowship at the Hunstead Cortese Center. He serves as the vice chair of patient safety for the ASPS Health Policy Committee, and he's an expert in body contouring in patients with high BMI, significant weight loss, and lipedema. Dr. Ali Jafar is a board-certified facial plastic surgeon and division chief of facial plastic surgery at Kuwait University. He completed an AAF PRS fellowship at UT Houston and residency at University of Ottawa in Canada. Dr. Jafar was awarded the 2024 Best Research Paper for ASJ Open Forum for his study entitled Soft Tissue Facial Changes Following Massive Weight Loss, Secondary to Medical and Surgical Bariatric Interventions. And our final discussant, Dr. Julius Few, is a board-certified plastic surgeon and founder of the Few Institute of Aesthetic Plastic Surgery in Chicago. He's a leading contributor to research in facial rejuvenation. He currently has work on GLP-1 medications under peer review, and he is a section editor of the Aesthetic Surgery Journal. So welcome, and thank you so much for taking the time tonight. I know we all have busy schedules. As always, we will have poll questions pop up during the course of our discussion, so please feel free to put any questions you have in the chat box, and Dr. Zamani will present them to us. Without further ado, I will let Dr. Zamani kick off Journal Club with a presentation of our article.
Thank you for that. So welcome everyone. And we're so excited today, as Dr. Sarhaddi has mentioned, to discuss this really exciting article and very relevant today. So this article is authored by, senior author is Dr. Wei-Chen, who unfortunately wasn't able to join us today. But the title of the article is Semaglutide and Postoperative Outcomes in Non-Diabetic Patients Following Body Contouring Surgery. Right. So in this retrospective cohort study, the authors utilized the TriNetX US Collaborative Network, which obtains anonymized health records from 62 different healthcare organizations within the US. And the patients that they included in the study included non-diabetic obese patients who had undergone body contouring surgery between 2021 and 2024 after bariatric procedures. And this included about 109,000 plus patients. And they excluded patients that were not meeting criteria due to conditions that could affect their wound care healing. These patients were then further subdivided into two cohorts. Cohort A were patients who'd been prescribed semaglutide for a minimum of 6 months before undergoing their most recent body contouring procedure. And cohort B, which was about 104,000 patients who consisted of non-diabetic individuals who also had a history of both bariatric surgery and body contouring surgery, but who had not received the semaglutide for the 6 months prior to surgery. Then they performed one-to-one propensity score matching to achieve a total cohort of 4,157 patients for their study. The outcomes that they specifically looked at were postoperative outcomes of bariatric contouring surgery with specific emphasis on certain complications within the first 30 days afterwards, including wound dehiscence, delayed wound healing, infection at surgical site, nausea, vomiting, and diarrhea, hypertrophic scar formation, and surgical site pain. And what they found interestingly was that compared to their control cohort, the cohort with the semaglutide treatment prior to surgery showed an almost twice the increased risk of wound dehiscence, more than 2 times the increased risk for delayed wound healing. Again, almost twice the increased risk of surgical site infection, more than 2 times the increased risk of nausea, vomiting, and diarrhea, 1.4 times increased risk of hypertrophic scarring, and 1.8 times increased risk for surgical site pain following their surgery. So this brought up a very interesting few points for discussion in their paper. And that was to acknowledge first and foremost that semaglutide affects metabolic processes and wound healing and immune responses. And beyond just side effects that patients experience and sometimes complain about, this can actually affect our surgical recovery that we see in our patients. So for example, the effect on GI motility and absorption could be leading to nutritional deficiencies that manifest as wound healing issues. And the immune modulation effect of semaglutide can be putting patients at increased risk of infection. And so this really emphasizes the need for further research on the impact of semaglutide on surgical recovery and long-term outcomes, in addition to all of the other pharmacological effects of it. So what are the clinical implications that we need to consider when we're seeing more and more patients with semaglutide and considering body contouring surgery? First and foremost is 6 months of semaglutide better than lifestyle modifications such as established exercise? Well, for example, we know that exercise has been well studied for its positive effects on cardiovascular health, insulin sensitivity, and overall metabolic function, and it mitigates some of the risks that we're seeing with semaglutide. The other thing that's notable is that there's potentially a role for developing a specific risk assessment tool for semaglutide that will allow surgeons to make better decisions on a case-by-case analysis for patients to determine if the benefits of using semaglutide prior to surgery outweighs the risk for that particular patient. And then it also underscores the need for patient education to really discuss the potential complications that are associated with the use of semaglutide prior to surgery, to discuss the other choices for preoperative weight management strategies and make the best decision for that particular patient, and to set realistic expectations for outcomes, including the potential for complications. So the recommendations that the authors made based on this for clinical consideration is that they do recommend discontinuing semaglutide 1 to 4 weeks preoperatively, and then resuming on a case-by-case basis based on patients' recovery and nutritional status. Additional strategies to reduce risk should also be considered, such as surgical staging to help reduce the overall stress on the body and lower the risk of complications, especially if the patient has pre-existing comorbidities and or it's going to be a complex set of procedures. Also, as always, there's a emphasis on nutritional optimization with screening for deficiencies essential for healing, such as vitamins A, C, D, zinc, iron, and then targeted supplementation based on any such deficiencies. And last but not least is the emphasis on lifestyle modifications, such as healthy diet and consistent physical activity to promote overall health. And that was it. Thank you.
Thank you so much. This article really did bring up a lot of important points. Pretty much all of our patients are on GLP-1s, at least in my practice, whether it's face or body. And I don't personally have a routine protocol for evaluating these patients in terms of nutritional deficiencies or optimization. So I wanted to shift to our discussants. Thank you so much for being here. And I'll start with you, Dan, if that's okay. I want to know how you, because you do most of the body contouring, or mostly body contouring, do you have any protocols in place in terms of how you routinely evaluate this patient population, the GLP-1 patient population, and how you nutritionally optimize them, or is it on a case-by-case basis? If you wouldn't mind sharing.
Sure. Well, I've been basically doing the same protocol for my bariatric patients anyways. And so we just dovetailed that into our GLP patients also. So for anybody that I'm doing any kind of body contouring work on, we always assess their nutrition. We always assess labs, including a CBC and a CMP, including an albumin. So we've been doing that for our body contouring patients, actually just about every single surgery patient since the start of my practice. So we really haven't changed very much in terms of the GLPs. We just make sure that the patients are off of their GLPs 4 weeks before their surgery, because we really do want them to actually start eating and increase their nutrition around the time of surgery. And I feel that 4 weeks is an optimal time to be able to go ahead and do that.
So for my practice, and again, I don't have a massive weight loss patient population. I do primarily face. So it's definitely new to me. We base our time to hold GLP-1s for patients just based on what anesthesia tells us, which is 2 weeks. I wonder if, Dr. Jafari, if your patients, if this is a new patient population for you, and whether or not you have protocols in place, and how you manage these patients preoperatively, if there's a routine protocol or a case-by-case basis.
Yeah, pretty much case-by-case basis. I don't have any routine protocol, but again, face is a little bit different than body contouring. So I usually will order labs for them, like usual CBCs. In some patients with a massive weight loss, I will do albumin just to kind of make sure their nutritional status, and sometimes like a B12 as well. But usually it's a case by case basis. There's no kind of a specific protocol that I would the routinely I would do on all patients. Also, with faces a little bit different. We've seen patients who lose a lot of kind of have a lot of skin laxity and fat ptosis as well, and kind of in the face. So I think it's and also the population is a little bit different. So it's uh, kind of we don't do a lot of so with face. I mean, a lot of it is like facelifts and neck lifts, if any. In fact, a lot of those patients who have massive kind of weight loss, we rarely do facelifts on them unless it's really profound laxity. A lot of the time, it's either a minimal facelift, if any, or a lot of it is like use of fillers and fat grafting, because there's a lot of devolumization that I see, at least, especially in the mid cheek and the temples.
And that tends to address the patient's concerns after the weight loss as well.
Yes, it does. Except for the patients who have a lot of skin laxity, then those who like especially in around the neck, most of the time it's the neck. So we'll do a neck a neck facelift basically.
Very nice. Dr. Few, could you weigh in on your experience as well? I know you do a lot on skin health, and you have your own research coming out. How do you manage this patient population in your practice? With facelift, neck lift, it's not as much fluid shifts and blood loss potentially as body contouring.
Right. Well, first of all, Deniz and Maryam, thank you for moderating this. This is it's such an important subject that I think we're only going to see it grow, and also my fellow discussants. I think, like you, I have primarily a facial practice. And I started looking at this a couple of years ago, and you're kind to point out that we have a paper that's hopefully soon coming to publication, and also an open forum. But I think the bottom line where I started to really look at this, and there's much more detail in our publication, but there is something very uniquely different going on at the dermal epidermal layer as compared to what we're seeing in just massive weight loss. And so I have a significant cohort of patients who have had post-bariatric facelifts. I've had patients who have had natural massive weight loss through diet and exercise, in excess of 50 pounds weight loss for facelift. And then this cohort, this is a totally different animal. And, we spent the last 2 years digging through the NIH, and there is a ton of literature that is largely accessible if you want to dig for it, that really goes back to the whole idea that one of the main GLP-1 RA indications, the early indication that never came to bear before diabetes, was psoriasis. And this was a medication that was tested. It has significant clinical power in that indication, but it never bore fruit because there wasn't enough of a business model for it. And so then there was a pursuit in diabetes. And so what I think is really important to note is that and I think there's lots of data to support it, there is a very, very similar mechanism of action in terms of cytokine alteration that is comparable to glucocorticoids. And so, or corticosteroids, there is a direct influence, in particular TGF-beta and IL-6. And so what this means to me, if you look through the kind of the pathology of change, it's a great drug for those who, for example, have hyperglycemic issues and diabetes, where you have poor wound healing and then modulating that. It's also a great tool for a lot of other immune-driven indications. That's why there's, everything from hypertension to you name it is being looked at for this drug. But as it relates to us, I think it's interesting. So many of us have been looking at nutrition. I don't think that's the culprit as in its entirety, because all of my patients, whether they're on GLPs or not, but especially GLP-1 receptor agonist patients, we have them all undergo a formal medical evaluation. I don't do any of the workup. I make them undergo a very detailed formal evaluation before they even get to the OR. And so largely they're nutritionally optimized. But even still with that, I've had 2 fairly significant acute delayed wound healing kind of cases, as well as I had an unusual seroma-like case that, again, it did not make sense. And I found that I have to resect more skin in a facelift. I've done a reasonable share of facelifts. And I think that what we're seeing, and there's more of this to come, it doesn't seem to be weight driven. I've done facelifts in patients who have been on GLP-1s for as little as 6 months and maybe 10 to 15 pound weight loss, and they still seem to have this dermal abnormality. So I think the real question in my mind is kind of the question of not so much before surgery, but what are we doing after surgery? That's going to be the bigger question that I'm curious about. I think they touch on some really interesting data points, and I'll give everybody time to talk about it. I'll make my one last point, which is, the approaching 2-time risk of things like wound dehiscence, hypertrophic scars, and the like. They're all part of a continuum. As we know, if you get kind of less than ideal approximation of dermal and epidermal edges, then you're going to get hypertrophic scars. And so I think it's part of the same continuum. And what's really interesting is that if you're disrupting, in particular, TGF-beta 1, you will alter normal fibroblastic activity, and that can explain in part the issue. It's almost like if you were to do, a lower body lift and then you pulse somebody with steroid. You have to wonder, how is that going to play out? And if you do that in everybody, I think there's going to be a significant potential impact.
So in terms of, and that's really interesting what you said about what's going to be important is potentially post-operative. Can you expand on that a little bit more? Is it in terms of
it's kind of, I think it's a question of when you start after the surgery or when the patient starts after surgery. So I'll be honest, I hadn't thought about this until we kind of discovered what we did in our research. If there is an immune altering process that ultimately affects kind of the wound healing pathway, which this does, then the question is, do we approach it in a way that is similar to what we would do for a corticosteroid? And that, I think, is going to be the question is, do you, if you have a chance to either, reduce the dose or delay the dose or get past a certain point of wound healing, maybe you don't put somebody back on it at a week. Maybe you wait 2 to 4 weeks, maybe. So I think this is all going to be part of research that needs to be elucidated. And so that, I think that's the big question to me. And I've had patients ask about this for elective concerns now that, I'm starting to talk about some of the concerns that I'm seeing with this.
Dr. Krochmal, do you see any differences in your post-bariatric patients versus GLP-1 patients in your practice for the body? Oops.
Dan, I think you're muted, bud.
Dan? Oh, sorry. There we are.
Thank you for that. Thanks,
Yeah.
Dr. Few. Yeah, that's a really, really good question. And just kind of thinking about my own practice, I actually still think I see more complications in my bariatric surgery patients. And I think some of that is because a lot to what Dr. Few just mentioned, that there are so many things beyond just the nutrition that these medications may be doing. But the fact that we stopped this 4 weeks beforehand, I wonder if that is kind of allowing body to kind of get back to baseline to kind of mitigate some of those non-nutritional aspects to this particular medication, because we do stop it so early. You can't undo a gastric bypass,
No.
but you can certainly maybe get back to baseline by stopping these medications. And we restart them about 4 weeks afterwards. So in my practice, I think because we really do emphasize nutrition, stopping the medications, we try to scare the heck out of these patients that if they don't stop these medications, they will get these massive wounds and infections. And we do really pay attention to their nutrition and their functional status around the time of surgery, that we are able to get them through it relatively safely a lot of the time. So for my practice, I actually still think that the bariatric patients have a higher risk of some of these complications, but I don't necessarily have the hard data to back that up. But I think it's something that I should probably look into.
Seen. Dr. Jafari, could you weigh in on this?
Yeah, so I agree with Dr. Krochmal that with bariatric patients, I do find more complications, especially with doing like facelift. I wonder if it's a nutritional deficiency thing that actually impacts the wound healing post-op. And then the other thing is with the GLP-1, it's a lot more younger people are using it. So patients in 20s and 30s, and they have lost significant amount of weight over a short period of time. So one challenge is actually is counseling those patients. I see a lot of them coming in and say that they want something done minimal, and they wonder if in the next 30, 40 years they need another revision and maybe further revision, facelift, if that's if the first surgery going to impact that. So I think counseling is a big thing. And then what I've seen also is the muscle loss, which is interesting. So
Even in the face.
even in the face, there is a muscular atrophy, like facial muscle atrophy, and that I have seen in those patients. There's no data to tell, but I feel like even doing the actual surgery, I do feel the muscle, the S mass is very thinned out. I wonder what, like, if this is like I think as Dr. Few was explaining, is it like a steroid effect that we're dealing with that's causing the muscles to thin out? And you see them a lot, like loss, like in specific areas of the face, which is very interesting. So Yeah, so it's a different population that we're dealing with, and we'll be seeing more and more of those. Um, the other interesting part is that there's no study that actually compares dose response, so of the GLP-1 specifically,
Mhm.
like is there a specific dose of GLP that would trigger muscle versus fat loss versus which a study that probably could be done, but I don't know if how feasible it would be.
Mhm. There was a study that I recall that was talking about the predictability of the thickness of this mass in phaedra. I'm not sure if this rings a bell, but basically, I think it was an MRI study or something like that that looked at trying to
Yeah,
predict the
MRI
thickness
study,
of
yeah.
this mass, and it was literally the only thing associated with it was age. Um, Dr. Few, do you notice your younger patients on GLP-1s with a thinner mass than you would typically expect?
You know, it's an interesting thing, and I think that what Dr. Jafari was just saying, I agree with. There definitely
Mhm.
appears to be a fascial change as well, which again I think it is probably linked to the what we theorize to be the pathophysiology, that there is a collagen reduction process that is happening.
Mhm.
Um, and I think most people, I mean, it's funny, we always think of skeletal fascia as very dynamic and turning over. You think of the tensor fascia lata as a great example. But I mean, our facial fascia is also very much so equally dynamic. It's constantly turning over in terms of its collagen makeup. And there's certainly some data to suggest that that is what happens, and that turnover process slows dramatically as patients get older. It's the reason why a thin 75-year-old facelift can be tricky if you're trying to do an extended SMAS.
Mhm.
So I think, you know, again, looking back over the last 30 years of that data, um, I do believe that there's probably something fundamentally happening to the fascia. So I will, as an example, I did it not too long ago, a facelift in a 43-year-old woman who
Mhm.
was very thin, wanted, for God knows what reason, wanted to lose 5 or 6 pounds, did micro dosing of Wegovy under, I don't even know who was prescribing it, to be honest. But in any case, was doing this. And it was a tricky facelift. Her skin was very thin. Her SMAS was not great. There was no way I was going to try to raise that, and it was just a plication case. The interesting thing is, much like an older person, even though she was in her 40s, you also reap the benefit of it, meaning that if you can assess, I think, for how much skin to resect and how much tension, which I do think is a learning curve in this population, they do scar really well long term. They scar
Mhm.
incredibly well. I would argue that it's some of the best kind of facelift scars that I've seen. So it's kind of like, I mean, it may be tricky
Like
in a
old people's skin.
body lift, yeah, but like older people, they're some of your best results. You're going to see
Mhm.
at any conference. They're going to show older people ideally because it
With an
makes it
invisible
look good.
scar.
With an invisible scar.
Mhm.
Look at how great I am. So I think that this is, to me, as I look at this more and more, I remain even more fascinated by it. And I
Mhm.
think the points of this, the Journal Club, are really bringing out some great points.
Yeah, I mean, these are things that and again, Dr. Krochmal, I don't deal with a massive weight loss population very often. Most of my facelift patients are older patients, or kind of like what you would expect in terms of facelift. My younger patients, like Dr. Few was saying, their skin is like bubble gum. Like out on the table, I'll pull it tight. My 43-year-old facelift patient who lost 80 pounds on Ozempic, and I literally, within my, like, in front of me, it's like relaxing again. I'm like, okay, you pull it tight again, and it relaxes a little bit. I've never taken off so much tissue off of one person, and I do a composite, like deep plane extended. So it's not just the skin that I'm pulling, it's this mass too. Do you see this kind of thing in your massive weight loss patients on GLP-1s versus bariatric, or in general?
Yeah, I've seen it on just about everybody. Interestingly, it's we're only, at least when I'm seeing my patients in my clinic and they're talking about body contouring, I'm only kind of seeing them at one period of time. So I'm always kind of wondering, well, how did they get to that weight gain to begin with? Have they been yo-yoing, ping-ponging? And so, yeah, I do seem to think that the tissue quality for some of the GLP patients that have lost 80 to 100 pounds is a little bit different compared to the patients that have lost, 10 to 20 that just also happen to want body contouring. So I do evaluate every patient individually based on their skin quality, because I have people that have not been on GLPs that have terrible skin, and people that have been on GLPs that have great skin. So I do think it's important to evaluate each patient individually. But yeah, I agree. There's just something to the patients that have been on GLPs for longer, that have lost a lot of weight, that the tissue is just a little bit different.
What about your patient's age? Do you feel like your younger patients have unusually, because we're seeing younger patients, I mean, at least in my practice, I'm seeing younger patients with more laxity than you would expect because of weight loss. And I know that's completely different from a practice like yours, which is geared around massive weight loss, but you did do a neck lift today, sir. So, so I'm wondering if you're seeing worse skin on younger patients that you would expect. Maybe, I'm not sure. I don't even know. Oh, you're muted again.
You're muted.
There you go.
You'd think at this point I would know about how to mute and unmute.
It just means you're incredibly courteous. That's
responsible. Yes.
That's what it is. That's what it is.
Thank you, Dr. Few. I appreciate that. Yeah, that's something that now that you've mentioned it, I will probably pay a little bit more attention to that.
You gotta tell us,
Yeah, I wish I had a really, really good answer for you. But at least in my practice, I see such a variety of patients, including just in young patients, when they've gained the weight, if they've kind of ping-ponged back and forth in terms of the skin quality. I can't necessarily point to one specific thing like it's GLPs that's really affecting it. But just in general, I think anybody that's lost a significant amount of weight, bariatric surgery, or using the GLPs, their skin is just going to be different than their age match cohort.
I think we've got something in the chat box, Deniz.
Yeah, let me see. And then I just
I'll
want to
take.
Oh, would you mind?
So yeah, I've been keeping an eye on the chat box. And again, everyone here, please feel free to put your comments and questions in the chat box, and we'll definitely sprinkle them in and get our discussants, pick our discussants' brains on them. So one of the questions that came up earlier in the discussion, and we've been doing a lot of touching upon, which is just noticing that there are some changes with regards to how these patients are healing and the potential roles for various things such as nutritional deficiencies, et cetera, in them. So it's a two-part question. So the first is, do any of you look for specific things such as hair loss, facial fat atrophy, or other signs to trigger whether nutritionally deficient patients are, to guide what kind of labs you're doing? Or is it kind of as Dr. Few seemed to suggest that in your discussion that you're doing a broad scope panel on anyone who is on GLP-1 to assess for a variety of nutritional deficiencies? Are there any particular physical manifestation, signs, symptoms that you're looking for, and based on that, do you have like a triage system of what panels maybe you test for, or is it kind of a broad scope? And if so, what exactly do you test for? I know we've mentioned CBC, CMP, and albumin in general, but is there anything else?
I would test them for thyroid, like TSH sometimes.
If you see those signs.
Yeah.
Dr. Few, are there any red flags for you in these patients just on initial physical exam that would prompt additional?
I really treat everybody like a red flag. So that's the honest answer.
Everyone's a walking red flag.
Everybody is a walking red flag. I'm starting my 26th year doing this. Everybody is a red flag, honestly. So, I mean, it's funny. And again, everybody has their style, but for me, I think there's comfort in sharing. And so I like the idea of somebody who's worked with, and oftentimes my patients, they've had very rigorous medical support through their internist, endocrinologist, and so on, that they all have ideas and they all have feelings of what is optimal. And I just feel like it actually, I can't tell you how many things have been unearthed by a really good endocrinologist who we could think that we know all the things, but I mean, listen, I did critical care a long time ago. Yeah, I'm not going to be the one to try to do the workup for somebody who's having an elective procedure. So I think that's the element in my mind. And I'm just, for me, as everybody on this panel has pointed out, there's something different about this group. It may be fascia, fat, or some combination. The truth is, there's histology that shows that we were right. And this histology was in the development of the product for a psoriasis medication. So it is a real thing that is happening.
One of the interesting things you brought up earlier was discussing, Dr. Few, that you thought that this, in very similar immune modulation manner, acts like steroids. So our one of our chat box questions is, what is the thought on preloading patients with vitamin A to help with that? Is there any utility to that?
This is somebody who understands the burn literature, because that is absolutely a proven fact. And it was something we did in terms of, so whoever pointed that out, it's a brilliant point, and it is the basis of what I've tried to come up with. The only thing you have to worry about with in particular first of all, bioavailability of vitamin A is tricky. So really the ideal way traditionally to give it is IV. The problem that you run into, especially with this group, is hypercalcemia, because there is a direct link to interrupting kidney excretion of calcium with high dose vitamin A. So you really have to, again, these patients, if you're going to do vitamin A, typically it's IV, or if you're doing a larger dose, there's just a tolerance issue. But that is incredibly astute. And I do think there's something to the idea of vitamin A. Actually, I came up with something for this that I think is interesting, which as soon as phaedra and company decide that it's worth it.
Would you share it with us? It's like
Too soon.
The sneak peek, if phaedra says I can say it. So and this is exactly, it's so funny because whoever asked about the vitamin A, they definitely either had burn experience or they're in my era of training, because that was like a pimp question. I mean, as an intern, I was carrying vitamin A bags around practically. So I think really what I came up with, because I'm a biochemist at heart, was a highly bioavailable form of topical vitamin A. So this is what we put under study. And thanks, Deb. You're dating both of us.
I'm in your era of training.
So in any case, what we've kind of come up with is indeed that is the model. And guess what? There's some really dramatic results that have come from using this as an adjunct in facial aesthetics. And so, like I said, as soon as this is able to be published, I promise you, it will be, especially Dr. Foreman, you will appreciate this. It definitely will make sense. And I think that is, kind of in my mind, how it proved that this is a corticosteroid-like effect is how dramatic the skin responded to the treatment based on our placebo-controlled study. So I think that this is, it's kind of, I reverse kind of concluded this by the response of the skin. And I do think that there's definitely room to continue studying, but it's an interesting idea.
And there was an additional question that just came in with regards to Tazorac 8 weeks prior to facelift.
I think that's an interesting one. Tazorac definitely has a fibroblastic like turbo. This is more in the derm space. They use this particular agent. The only thing I would worry about is I'm not sure how the immune modulating capability of Tazorac would play with this. And there are some, again, I kind of dance between derm and plastics. There are some anecdotal stories of some challenging potential interaction there. So I'm not sure that I would dole that out as an answer. But I think it's an interesting thing to, maybe somebody could look at. But I do think like I said, the anecdotal concerns of like idiopathic things that do happen on Tazorac, I'd be a little leery of it in this population.
That's really interesting.
Question.
And then just to bring it back a little bit more in terms of, we have this extensive body of knowledge about wound healing and other adjuvant therapies that can help with wound healing in general, regardless of what the underlying cause is. For example, tissue tension modulation devices that are on the market, especially for body contouring devices, methods of delivering increased oxygen to the tissues, whether that's through hyperbaric oxygen therapy, carboxy therapy, or you name it, and then additional topical applications. Do any of our surgeons here utilize any of that? What is the thought process about, just looking at this from a more comprehensive perspective of this is a patient who is going to be, maybe immune challenged, and how can we help them in terms of their treatment, whether it's prolonged antibiotic therapy, counting for utilizing drains where drains may not have been used previously, just based on potentially higher risk of stromal formation, longer drain usage, and those adjuvant therapies. Dr. Kochmal, with your body contouring patients, any ideas there?
Yeah, that's a lot to kind of unpack there, and all very, very excellent questions. I try to just have my set protocols for just about everybody that I do, regardless of whether or not they're on GLPs or whether they have undergone bariatric surgery or whether they just haven't, and they just want body contouring. We have everybody stop certain supplements a couple weeks ahead of time. We have everybody see their primary care doctors for medical clearance, because sometimes they have stuff buried in their medical record that they forget about or they just don't want to share with us, to try to get them completely optimized. I basically perform just about every surgery relatively the same for everybody, and then we just pay attention to things post-operatively. So you mentioned drains. I used to do drainless, and I kind of went back to drains. We see patients weekly to see how they're healing and make any modifications that we feel that we need to. So I don't necessarily think that I'm proactive in terms of separating out the patients and what I might need to do, but I'm just a little bit kind of reactive in the post-operative period for maybe maintaining surgical tapes on the patients for a little bit longer, maintaining the drains based on their output, continuing some of the nutritional supplementation with collagen if we need to. So I don't know if that really answers your question, but that's at least how we do it.
Dr. Jafari, do you have what about for yourself or in terms of your facelift populations? Do you do any adjuvant therapies? I mean, the tissue, tension reduction doesn't really apply, but the other, increased oxygen deliveries or topical medications, anything like that for you?
No, not specifically, unless there's a higher risk of like wound dehiscence in certain patients. Then basically I would keep them on a certain kind of ointments or creams, and kind of monitor them, but more closely, but not a certain protocol or certain treatment post-operatively for those patients. No.
Perfect. And Dr. Few, I know you have your secret recipe coming out. We're excited to hear about it. But any other pearls about anything else that's not proprietary you can share with us?
So I don't know, time's gone so fast. Pre-COVID, I was in Brazil lecturing when the idea of the surgical net was first born. And at first, once I got past the horror of the idea of it, I thought it was, I thought, now, you have to understand, this was a long time ago. You have to imagine 10 years ago, somebody putting that up on a screen. But in any case, I saw this and I thought at first it was madness. But then when I thought more about what they're doing, it's controlling the skin envelope and closing dead space. So for the last decade, for my facelifts, I do a modified, it's not even a net. It's more of, think of it as buttoning down the skin to the fascia. So I'll place strategic, like usually it's 3/0 nylon, transcutaneous as a mattress that just holds the skin in place. I do a little bit more of that, especially post-auricular. I feel like in these GLP-1 patients, it's really hard to gauge the tension back there. And so I've quilted that to the post-auricular mastoid fascia, and it has really, really, really helped. So I haven't seen some of the issues I think I would be concerned about. I stopped using drains and facelifts about a decade ago. And so for me, I think it's more of really the idea that and again, as Dr. Jafari pointed out, I think the hard part in this group is gauging the tension on the skin to get your result, but at the same time, not have the whole thing to hiss. And so the bubble gum. I love that. I'm going to use that because it is like
It literally
truly is like bubble gum.
Yeah,
And
true.
it's truly unique. And so I think that, and it's here to stay. I mean, like I said, I think GLP-1s, I don't think it's necessarily dose dependent. I think if the dose is enough to cause the desired systemic effect, whether it's weight loss, cardiovascular benefit, there's studies now looking at the effect on LPA, you name it. If it's enough of a modulating effect to actually cause that benefit, it's enough to cause the side effect.
Got it. Switching gears just a little bit, unless anybody has anything more to add in terms of like pre and post management protocols, anything. It seems like we're all just still trying to figure it out for the most part. But in terms of patient expectations, from what I've seen, and I'd like to know if our discussants agree, we're getting younger patients with more laxity, getting surgeries that potentially they weren't getting sooner. Are you seeing a difference? I guess I'll start with Dr. Krochmal in patient expectations in terms of body contouring surgery in these patients versus bariatric patients. And again, I know a lot of these patients have had bariatric surgery in the past, but I do feel like it's a little bit of a patient population. What have you seen, or what do you think?
It's a good question. In general, I think just about everybody has unreasonable expectations.
The walking red flag thing.
Exactly, it is. It's like Dr. Few mentioned, everybody just comes in with their like blinking red lights just about everywhere. So I've got to be pretty careful. But I think that's a very, very wonderful question. And I do think that there is something to that. I do think that this might be the wrong way to say it, but for some patients, kind of doing GLPs is kind of an easier way out than somebody who's undergone surgery that understands the risks, the complications, the recovery, the expecting to have one body type and not having it from one surgery. I do think that they have a little bit more tempered expectations for what can be achieved with surgery versus somebody that has not had surgery before, that has just gotten a shot, gotten a pill, and has lost the weight, and they're kind of thinking that surgery is going to be easy and you just wave a wand and they're going to have this beautiful, wonderful body that they've always dreamed of. So yes, I do think that in my practice, the patients that have only been on GLPs that have achieved the weight loss maybe are having a little bit of a higher expectation than my patients that have undergone surgery. I'd be curious what other people think.
Dr. Jafari? Have you seen different patient expectations in this, or surgical expectations in this patient population?
Yeah, I mean, we're dealing with a different patient population, more younger people, and their expectations are definitely different. A lot of them, when they come to the clinic, they want what they call quick fixes. So they lost significant weight. They did not think that they're going to have significant facial changes. And a lot of them actually looking into getting, something that's non-invasive. So like radio frequency, microneedling, fillers, they're not pro getting any surgical interventions. They want basically those quick fixes. So it's a different expectation. And when I discuss with them facelifts or neck lift, they always ask the question, so I'm too young for this. What if I'm turning 50s and 60s? Do I have to redo that? Is the complication going to be higher at that time? And how am I going to heal? Because we have not really studied this population particularly. And we don't like really know. There's not a lot of studies to actually like, especially like facelifts and to basically look into complications post like GLP-1. So patients have been on GLP-1 and then had a face and neck lift. So what kind of complications do they get? I mean, this was a really nice presentation of the study on complications post GLP-1 and body contouring, but we don't have anything similar for facelifts and neck lifts. So we already identified some complications for body contouring, so that could actually translate to facelift. So in a younger people who have a facelift and neck lift, and they come in with a complications and they are younger, with expectation that is really high, those are a challenging population to deal with. So it's we're basically talking about a different subgroup here.
Right. Dr. Few, how do you counsel your young GLP-1 facelift patient for expectations?
Yeah, I mean, I think, and like piggybacking off of what was just said by Dr. Jafari, I think it is a new horizon. I'm honest with my patients. I say this is a relatively new kind of issue as it relates to change, because the patients themselves have pointed out, that really they're disproportionately affected by this medication, especially on their face. Their skin appears duller and so on. So number one, I'm very reluctant to try to hypervolumize these patients because, again, the skin is less predictable. I'm much more likely to offer resurfacing tools, especially laser, because I think that kind of helps to do a reset, especially pre-facelift. And then when it comes to facelifting, while I think this body contouring paper, which is very well done, captures that group of post-bariatric patients, I think for facelifts, it's going to be trickier in the sense that you're much less likely to get wound dehiscence in a facelift, especially with an experienced facelift surgeon. But no one, and I challenge anybody to try to come up with a study that actually judges patient satisfaction, because that's really what it's going to boil down to. How many of these cases have early relapse of neck ptosis? How many of these cases have early relapse of the initial indication for their presentation? And then what are you going to do about it? So I think that for me is really the question. And ultimately, I see my dear friend Val Lambros just joined, who I've learned a ton from in my life. But in any case, I think that ultimately, in my mind, the bottom line is, it's kind of a new frontier, which I think everybody's touching on. And I do think the key at this stage is notifying or letting our patients know that we don't know, and then working back from there, because that's part of informed consent in my mind.
Yeah, again, I'm 5 years in practice, not quite. And I've gotten this patient population and it's very challenging. It's not the standard young patient. It's the young patient that comes out tight as a drum. And then 6 months later, you're like, oh my God, what am I supposed to do? Am I supposed to offer them a free redo? Am I supposed to, it's hard for me.
I mean,
'Cause
I
I'm
think
new,
it's,
but
I
I
think
guess
it's, I think it's a humbling thing no matter what. I
Mhm.
think that, you know, because if you're too aggressive on that skin that has kind of the appearance of almost like a worn out rubber band in some cases, then you will have to worry about bad scar, because the point that I mentioned, that kind of dermal epidermal reapproximation process, because of the alteration that has been clearly described in the derm space in terms of TGF beta 1, you run the risk of creating hypertrophic scars in the pursuit of perfection. So I do think it's again, there's a lot more to come from this, but I also think that prevention, and I'm not making a plug for my stuff, but I do think that trying to come up with ways nutritionally and otherwise to try to circumvent some of these effects on the dermal epidermal level is really where the focus will be, and then also fascia.
What I'm loving about this is just the difference hearing you guys talk about the facial aspect of this versus the body contouring aspect of this, where you guys are really kind of honing in on just that laxity, that bubble gum, where if you just have just several millimeters of kind of recurrent laxity, you're going to notice a significant difference versus some of the body contouring, where if you have a few extra millimeters of stretch, you're not really going to notice it. So
it's much more forgiving. It is, and it is
incredible.
Dr. Krochmal, you are nailing the issue, and I think now more than ever, especially with patients saying, okay, I don't want filler, I want a facelift, which is at an epidemic level. I have people in their 30s, early 40s coming in like their facelift is getting a shot of filler in their cheek. And the truth is, again, in this demographic that's microdosing for 5 pounds of weight excess, it's a different animal. The expectations, I promise you, they're up here. They're not just they're looking for the efficacy of that shot that you get with a novice filler patient, but they don't want any downside. And they want it to last a long time.
Long time. Yeah. It's I'm 42 years old. Am I going to have to get this again? I'm like, I don't know. Yes. Maybe in 6 months. I don't know. Well, we have 3 minutes left in the hour. Does anyone have any last minute questions? Anybody want to submit an editorial on this for ASJ?
Let us know.
I think it's coming. I think it's coming for sure. So
please.
And Val, I gotta say to Val, who I love as my big brother, I have a paper hopefully coming as soon as phaedra says that I can publish it. We've already conditionally been approved. So yeah, that is coming. That I think will answer some of the dermal epidermal questions.
Well, thank you guys so much. This was a wonderful journal club. Dr. Few, Dr. Krochmal, Dr. Jafari, I really appreciate your expertise and the time you've taken to join us. Looking forward to your publication. And if no one has anything else to add, we'll call it a night and we'll see you at the next one.
Wonderful. This was a great panel. Thank you very much,
Thank
Dr.
you.
Sarhaddi.
Everyone.
Thank you so
everybody.
much. All right. Bye-bye now.